because they are what we call neuromodulators. Botox is shown to reduce both the frequency and intensity of headaches or chronic migraines. It interferes with the release of pain-related neurotransmitters to help decrease the number or the intensity of the migraines that you have. So we do 31 injections into the muscles of the face, neck, and head. Like I said, we'll show you kind of those sites here in the next couple slides. And then if this is helpful, we can repeat it every 12 weeks. So you can kind of see the orange dots here are the injection sites. So 7 across the forehead area, 4 across each side of the head, and then 6, 10 across. 10 across kind of the back of the head, and another 6 along your shoulders. For these injections, we use very small needle, and patients do really well with them. I know 31 injections sounds like an awful lot, but patients do really well with these injections. Just due to the kind of the technique, I guess, and what we use for the procedure. So another kind of headache that we see often is what we call occipital neuralgia. Very specific type of headache. Symptoms are sharp-shooting electric pain that kind of start at the base of the skull, and radiate to the scalp. So there's 3 different nerves that are known to be involved. The third occipital nerve, the greater occipital nerve, and the lesser occipital nerve. Those nerves all kind of come off of the vertebrae of the neck, and they all have different courses up through the back of the head. On that right side here of this picture, you can kind of see here. So the third occipital nerve is this nerve here. So if you have pain that stays kind of localized right to the base of your skull, that's likely what we're dealing with. The greater occipital nerve, that goes more up and over top, so patients will describe that as starting here and just pushing forward over the top. We see it a lot of times behind the eyes of patients' forehead. And then the lesser occipital nerve here, you can kind of see the course of that too. Patients more describe that as starting at the neck and just kind of coming up around their ear, is what they typically present with. Can be unilateral or bilateral. Scalp tenderness, so if you're kind of pushing in and around this area, you'll feel that patients will tell me it's right here. As soon as you touch it, they know, and I know, I guess. So the cause of this is a little different than chronic migraine. So chronic migraine, like we said, is not well understood. The cause of this is pretty well understood. It's those nerves that we just kind of touched on. It's either an injury to those nerves, so you can get injuries with these nerves with things like whiplash, car accidents, things like that. Nerve compression, so where these nerves come up from the back of the head here, right through here, there's what we call a fascial layer. So those nerves have to kind of pierce through this fascial layer. Fascia is just a connective tissue that separates muscles. Anytime a nerve goes through a fascial layer, it can be entrapped in that fascial layer, just kind of clamped down on, which gives you side effects of the occipital neuralgia. And then inflammation is another big one as well. So mostly we associate inflammation with entrapment of those nerves, but not always. Inflammation can happen anywhere in the body. There's systemic disease processes, I guess, that create inflammation body-wide. We do see those from time to time causing things like occipital neuralgia. More so than not, it is very localized nerve entrapment or inflammation around that nerve. The treatment for this, we try physical therapy first. Myofascial release, so if it's true nerve entrapment, physical therapy is very helpful. It'll help you kind of break up that fascial layer where that entrapment is, mobilize those nerves a little better to kind of decrease the pain and symptoms. If physical therapy and conservative measures don't work, we can try what we call trigger point injections. So the trigger point injection is just an injection essentially into the muscle. We kind of figure out where that nerve is entrapped. Like I said, typically right at the base of the skull where that fascial layer is, and we'll go on both sides and we can get a needle into the musculature itself. So a trigger point is just another term for a knot. Like if you go get massages, they tell you have a lot of knots here, those are trigger points. Just balls of muscle that are not allowed to relax because they don't get good blood flow. So trigger point injections, we get into those knots and we work a small needle around to kind of create what we call microfenestrations, holes in those trigger points to help restore blood flow, try to get that muscle to relax a little more, and in turn decrease headache symptoms. Another treatment that we do frequently are occipital nerve blocks. So greater and lesser occipital nerve blocks, we take an ultrasound, and I can see those nerves with an ultrasound. Put a small needle right next to them and inject some lidocaine and some steroid in there. Kind of works twofold. The lidocaine will tell us right now if your pain goes away right now. We know that's what's causing it, kind of a diagnostic test block of that. The steroid then is meant for a little longer lasting effect, I guess, of pain relief. Especially if we're dealing with inflammation of that nerve, that steroid just decreases inflammation, helps decrease the pain in turn. And then we do also offer radiofrequency ablation of some of these nerves. The greater occipital nerve and then the third occipital nerve specifically. The lesser occipital nerve is not as reliably able to locate it just because it's much smaller than the other two. We have a good idea where it is, so we kind of, when we inject in essentially a fascial plane that we know surrounds that nerve, but the radiofrequency ablation is just a burning of the nerves. You have to be able to really see those nerves on ultrasound or x-ray to be able to burn them. So the lesser occipital nerve, or that pain kind of up and around your ear, that one's a little tougher to locate, so we don't typically do those unless we can identify it on ultrasound. The greater occipital nerve and the third occipital nerve, we definitely do ablations for. So diagnostic criteria for occipital neuralgia. Like I said, it's not laid out specifically like it is for chronic migraine. Based on history, physical exam, and nerve blocks, so kind of like we touched on, we use those diagnostically as a test. If you have these headaches and nothing else is working, even if we just put lidocaine around those nerves, if your pain completely goes away, we now know that that's what is causing that pain. Common pain description that patients kind of complain of is a constant dull headache at the base of their skull, and I've had patients tell me anywhere from every 30 seconds to every 15 minutes. It's a constant headache, and it shoots forward for 2-3 seconds and stops, and then shoots forward for 2 to 3 seconds and stops. Just kind of an on and off, sharp shooting pain up, back of the head, over the top, sometimes into the forehead and behind the eyes. As we discussed earlier, almost always associated with that scalp tenderness, so we can kind of palpate along that area. And a lot of times when we push on that nerve or the area around that nerve, you'll get the exact symptom shooting forward. And as kind of we already discussed, the nerve block, diagnostic with potential therapeutic effects as well. I may have jumped ahead of myself here and already kind of explained all these, but trigger point injections, as we said, they're just knots in the muscle. When those muscles knot up, they can either push on a nerve or they can impinge around a nerve. So trigger point injections are just injections into the muscle themselves, either with or without steroid to help loosen those muscles up, get them to relax, restore blood flow. The nerve blocks, kind of what we discussed already here, you can kind of see on the picture on the right there, where those nerves are, the greater and lesser occipital nerves anyway. The third occipital nerve we block right at some of the bony prominences in the spine. We use x-ray to do that instead of ultrasound. That's a little different procedure, but the same concept, I guess. And then the radiofrequency ablation, if we get a good test blocker, we can say, yes, that's what's causing your pain. If that doesn't last you, the pain relief doesn't last you for 3 months or greater, we can do an ablation on some of these nerves, which in theory provides a longer lasting relief, anywhere from 6 to 18 months at a time. The lesioning or burning of those nerves is what the radiofrequency ablation is. Depending on what nerve it is, if it's the greater occipital nerve and we can find that with ultrasound, we just park a needle right beside that nerve, do some testing, and then inject lidocaine around that nerve, and then do a lesioning or burning of that nerve. So cervicogenic headache is kind of a broad term for any sort of headache that stems from any sort of condition in the neck, the bones of the neck. So symptoms associated with this: pain in the neck that are worsened by neck movements or pressure on the neck. More specifically, if you do neck extension, if you try to look up at the ceiling and that really aggravates your headache or pain, that's a good indicator of what we call the cervical facet joints causing these headaches. These can be unilateral or bilateral as well, and these are referred to as a referred headache. So the headache itself is stemming from another area in the body, and the pain kind of goes elsewhere. So pain is felt in the head but originates in the neck. So muscle strain, arthritis of the joints in the neck, or muscle or joint injury can cause these. Some similar treatments, trigger point injections of the muscles. So facet joint injections. The facet joints are actually on the spine itself. They sit in between each vertebrae. Very specifically, and I might be jumping ahead of myself here again, but very specifically the facet joints of the upper cervical spine are what cause headaches. So we can do facet joint injections right into those joints, where we put a needle right into the joint itself and inject medication. Or we can do what we call medial branch nerve blocks and radiofrequency ablation. So the medial branch nerve blocks are just similar to the diagnostic injection that with the occipital neuralgia that we talked about. We put local anesthetics such as lidocaine around the nerves that supply those facet joints, and if your pain or headaches gets much better, we consider that a positive diagnostic test that that's what's causing your pain or headaches, and we can go ahead and do the radiofrequency ablation of the burning of those same nerves. So diagnostic criteria for cervicogenic headaches, again, not specific like the diagnosis for chronic migraine, based on your history, physical exam, and potentially nerve blocks. The common pain description is a constant, dull, achy neck pain and sharp radiating pain associated with any sort of neck movement. We often see decreased neck range of motion in these patients, and neck movement often triggers these. So you can't see these facet joints on this actual picture, but they sit on both sides of the spine. These are what the facet joint labels, I guess, are. So your C2-3 and your C3-4 are your most common facet joint cervicogenic headaches. So these are kind of the pain patterns that you would see with facet joint arthritis of those specific joints. Again, interventional treatments for these. We can do trigger point injections in and around some of these nerves. The facet joint injections, this actually gives a little better picture here. These are your, if you're looking at your spine from the side, these are your facet joints here. You can kind of see they took away one of the bottom side of this one, so this joint sits right in here. Those joints, these nerves, come near. They don't go through the joint. They come near the joint. Anytime you get inflammation into a facet joint, that has the potential to leak out and onto those nerves, which can cause symptoms. So it can either be inflammation or just the arthritis in the joints themselves causing that. And then the medial branch nerve block, so that needle right there in that picture is actually showing a medial branch nerve block. A diagnostic test block is what those are. We inject lidocaine in and around those nerves, and if you get a good response from that, then we know that if we burn those same nerves, you should get a little more lasting response from that. So as far as, I guess, a pain clinic visit to us, as far as getting into pain clinic, you can be referred from your primary care. This is what we typically see because primary care has either tried a lot of the conservative measures with you, medications, physical therapy, things like that have not worked. So then they kind of send you our way. You can schedule directly as well with us in pain clinic. We like you to have at least tried some other conservative measures first, such as physical therapy, medications, things like that. If not, it's not to say that we won't still see you if you schedule with us. You come in for consultation, and then we just do a pain and headache assessment. We kind of take down all these indicators here, and then we have you fill out a couple forms that just tell us like your disability that the headache's causing you. Gives us a little better picture of how this affects your day-to-day life, some of the qualities of the headache as well. Once we know that, we can do an assessment and then try to diagnose you with a specific kind of headache. So physical assessment, the neck range of motion, that really just tells us a lot about if we think that it's arthritis in the neck or anything cervicogenic causing that. We palpate in and around the muscles for trigger points. A lot of patients will have trigger points through their trapezius muscles here, their shoulders, that can refer up into the head, cause headaches. And then just some provocative maneuvers, things that are meant to replicate or aggravate the same specific pain that you're normally experiencing. Depending on what we think, I guess it is, we may or may not do x-rays and MRI. Not very often do we order lab work for any sort of headaches, unless you're on a medication that we need to do like see kind of where your peak and trough is for that medication being in your system, but not very often. So let me correlate the symptoms that you tell us, your pain assessment, your physical exam, and any imaging that we do. That kind of guides our treatment plan. So if you have not already tried physical therapy or medications, even as simple as Tylenol, ibuprofen, things like that, we would have you try all those first, just to see if those would improve your pain or decrease your headaches at all, before we would try anything interventionally. And then, as we kind of talked about all the previous treatments, the ablations, the nerve blocks, the trigger point injections, once you try kind of the conservative stuff and we do an intervention for you, then we follow up typically 2 weeks by phone and then 4 weeks in clinic, unless we already know if this works for you. And then we can repeat that intervention that worked as necessary. So key takeaways: chronic headaches affect many people and cause a lot of disability worldwide. Types of headaches are often misdiagnosed due to overlapping symptoms. They can have many causes but present with similar symptoms. Different treatments for different headache types depending on what's causing them. Conservative measures come before interventional treatment, so kind of as we already discussed, physical therapy, medication, and activity modification. If those things do not reduce your headaches, then you can come see us and we will see if you're a good candidate for any interventional therapy. Please schedule an appointment with us or ask your primary care to refer you to us if those conservative measures fail. What questions can I answer? Yes? Yeah, so it's a neuromodulator. So neuromodulator meaning nerves. It just modulates the chemicals that affect nerves. It decreases the amount of what we call inflammatory mediators, just things that cause pain in your body specifically. The biggest one is what we call substance P. It's a pain neuromodulator. It helps decrease that to help decrease headaches. Botox can also help to relax muscles. So if you have nerve entrapment, it can help relax the muscles around that entrapped area as well. Yeah, good question.
Do you work here in Sibley, or do you have to go to just people from Sibley have to go somewhere else?
Nope, we do all the stuff all the treatments that I just mentioned right here in the building. Yep. Yes.
If you have a severe headache, could it cause an aneurysm?
I would say that the aneurysm is probably causing a severe headache. Probably the other way around. Yep. That's something that's a little out of the interventional pain management realm, more vascular or neurovascular. But yes, I would say it would probably be the other way around. An aneurysm likely causing a headache. Yeah. Yes.
So can you use like those lidocaine patches, like slump paws or on your trigger points up around your shoulder neck?
You can use them, lidocaine patches, I don't know if you've heard of what a TENS unit, those electrical stimulation units, those can work well as well. They aren't, neither of those things are necessarily getting to the root cause. So kind of as I've discussed, trigger points are just a ball of muscle that's not allowed to relax because they don't have good blood flow. Calcium is the element you need for muscles to relax. When your blood flow gets disturbed, you don't get appropriate amount of calcium in there, so you get knots. So you're not necessarily getting to the cause of the problem or the root of the problem with those things, but definitely a conservative treatment if it helps you and helps your pain. Yeah. Yes.
I'm kind of a mess. I've had my neck fused 5 to 7. It's a 20-year-old fusion. I've had migraines for 35 years, diagnosed that way, but they're kind of like all the ones in this. Some are just like a giant hand around my hand back here. Sometimes it wraps around one side of my head or the other. You know, I've got the light sensitivity and the nausea. And when I got my neck fused, I was 34, and they said I had so much arthritis in my spine at that age that they had to do that. It was just a mess, and I was seeing a pain clinic when I lived outside Omaha, and I went in for these trigger point injections a lot. I've had nerves ablated. I mean, how long can you do it? You know, some things work better than others. Sometimes I'll get a headache, and I know that it's sinus. I can feel it's sinus, but when I get what I call a migraine, and I'm taking chemotherapy, I'm in bed for hours. You know, the pain is just unbearable.
Yeah.
And
To answer your question on how often can you do these things, it really depends on the treatment. And then, insurance guides a lot of what we can do. Medicare specifically, trigger point injections you can do every 6 weeks, as long as they've given you 50% relief in the past. Or you can do different areas, under 6 weeks, just kind of depends where those trigger points are. As far as ablation is concerned, we expect ablation to last anywhere from 6 to 18 months. You can repeat that as soon as 6 months. And that really doesn't have, repeated ablations don't have a major effect on those nerves, I guess. So when you ablate a nerve or you burn a nerve, you're just burning the outside perimeter of that nerve by design. That allows less pain signals to go, be conducted through that nerve, so you perceive less pain. Those nerves will regenerate or heal themselves, and however long that takes is the amount of duration of relief you typically get.
because I've had like acid point injections
Yep.
in my neck to get the ultrasound and all that. And I have a billion knots. I have alopecia, pain syndrome,
Yep.
fibromyalgia, all
Yep.
that stuff. So it could be anything.
Yeah.
But I've not really had treatment like that for about 6 years because my husband and I moved up here.
Sure.
I don't have as many as I used to have, but last year I had one every other day during the entire month, and I couldn't get away from it, and I just wasn't sure where my options at that point.
Yeah. Really kind of dependent on physical exam at that point.
Because years ago, I'd go to the emergency room and they'd give me a shot of something and partially knock me out.
Yeah.
And I'd be on the table for 3 hours and then they'd let me go home.
Sure.
It helped, but I don't know that it was treating.
Yeah. Yeah, as far as options, like I said, it really just depends on physical assessment. If we think, we know that fusions in the neck can cause what we call adjacent segment syndrome, or anytime you put hardware in the neck, it stresses the segments above and below it. That can put more strain on the facet joints. I think, if I'm not mistaken, you said C5 through 7. Yeah, so if you start looking at the 4 or 5 facet joints, there's about a 25% involvement in headaches from that. And when you get to the 3, 4 and the 2, 3, you're looking at almost 75% involvement of those two with headaches. So it just depends on where it's stressing on what segments, I guess, or what areas. As far as the fusion's concerned, as far as the myofascial pain is concerned, we can, like I said, we do trigger points into the neck muscles, trapezius muscles, things like that, which I'm sure you've had in the past. It's really about getting yourself to a good spot with the muscle pain, and then trying to get into physical therapy, and they can do some myofascial release, some dry needling, things like that will also help with that.
Thank you very much.
Yeah.
Migraine's genetic, running families, and another question, why do some people have one for 1 day and some people have them for 3 to 4 days?
There is a genetic portion to true chronic migraines.
Does it skip a generation?
That I do not know. I would say probably not, but
Okay.
and then as far as why some last longer than others, I have no explanation for that. There is no good explanation for that in any literature. Chronic migraines are, like I said, widely misunderstood on what's truly the cause. We think that part of that is because there's just so many things that are involved in what causes them, I guess. But.
And I know this isn't accurate or true, but when I've had them, my hair even hurts. And I know there's no receptors in my hair, but
You're not alone with that.
you know what I mean? That's how bad it is.
Yeah.
And do you age out of them?
Typically not.
Really? So they're not, you don't think they're hormonal?
There is a hormonal aspect to them, yes, 100% is. Yep.
So one of the things that works for me is I got it on Amazon, like everything else, it's an ice hat, and it's like a vinyl, and it has Velcro, so it's a circle, and it's got, I don't know, 30 or 40 small segments in it that are filled with gel, and you keep it in the freezer. And, it helps me when I get a specific one, like, I don't know, up in my temple, or the back of my head, it feels like I've been hit with a baseball bat. The ice does help.
Yeah.
If it's the big, hand over my head one, and it just feels really, really deep, it's not as effective, but it's better to have it than not. I don't know if that would help anybody
Sure.
else, but it's not that expensive, and I've gone through a couple already. Does that sound?
Yeah, so anytime that ice helps with anything, it's likely vascular related. So if you think about your blood vessels, if you get a pounding, throbbing headache, your blood vessels are likely dilated out, allowing more blood flow to the area, causing that pounding, pulsing headache. As soon as you put ice on that area, it shrinks those blood vessels down to probably help with that. So it can kind of vasoconstrict those blood vessels and help with any headache that has any aspect of vascular. Yeah.
What about ones, like, I went to an ear specialist and he told me I had in the ears. And there's times, I have to I get so dizzy from them, cause I have, one I get the most is through here.
Okay.
And yeah, it's usually just the one side, but my ears go with it too. And when that really gets up, I get so dizzy and stuff, there's times I have to crawl on the floor in order to get somewhere. Or my, daughter has to help me walk to the bathroom.
Yeah.
Because I get so dizzy. So, are those kind of treatments and stuff too, to help with that kind of thing?
So anytime you just start talking about dizziness, that's almost all inner ear related.
Okay.
We don't necessarily do any treatments for the inner ear imbalances, I guess. the nerves that we listed here, those are just kind of the common ones we see. There's other nerves that cause headaches. Greater auricular nerve will kind of start here and cause headaches up through this area. There's lots of different nerves that cause headaches. I just kind of touched on the main ones. Not to say that I haven't done a nerve block on something that I did not think was going to help any sort of balance issues, and it has. I don't have a great explanation of why.
But those headaches, when I get a migraine, it can affect my ear area, right?
Sure, yep.
It can.
Yep, so there's nerves, like I said, there's a nerve that comes right up here, kind of through your temple area, called your greater auricular nerve. That can cause it. That lesser occipital nerve, like we talked about, wraps up from behind. It can be both of them. There's other things too that can cause headaches in that area that are not nerve related. But yeah, have you ever seen a neurologist for these headaches?
Yeah.
And they sent you to ENT.
So what?
Did they send you to the ear doctor? Sorry.
No, it wasn't my, piece. My regular doctor sent me to because I was having so much problems with pressure in my ears and stuff like that.
Gotcha.
And that's what he's told me and stuff. But yeah, over the years, I have gone to neurologists, I don't know how many times, and they've done different things, but I've never
Never
had
found
much
anything that
help.
helped.
No,
Okay.
with any medication and stuff. No one's ever done like a therapy thing. I don't know what you mean by therapy for it.
Yeah, depending on what we think is causing it, I guess therapy can be a better option for some types of headaches than others.
So is that like a physical therapy?
Physical therapy, yep.
Okay.
Yep.
Yeah, I haven't had any of that because no one's ever, not even a neurologist has done that.
Yeah.
I know none of the medications I've ever taken that are supposed to be really common with helping, they don't help.
So I would say that we see that more often than you would probably expect. Medications that should be helping just don't. Some of that can be contributed to just a misdiagnosis. Medications that we would expect to help chronic migraine don't help occipital neuralgia. They have a lot of the same characteristics. So that's kind of where the misdiagnosis and trying some other things interventionally come into play.
And another with the, some people get like the eye blotches with their sight and stuff. Is that like part of the chronic or the?
Yep, so any visual disturbance, that's what we classify as that photophobia. Rarely do we see that outside of anything other than true chronic migraines.
Okay. And those they can be like different sized and stuff, because like when I get visions, you know how those really old TVs where you have all that static, that's what my vision will get.
Yeah.
And then,
Presents in patients very differently.
okay.
Yeah.
Because the other people that I've known, they say they have like the big blotches and stuff, so I don't know if mine was, because I never heard anyone tell them being that small.
Yeah, everyone, we see a lot of, I guess, variety of symptoms. Not specific to any one patient. Yes.
So I've been prescribed some Imitrex for
Yeah.
years. Is that, and I know that you've not examined me, but is that appropriate for the kinds of headaches I have? Or should I be looking for something else?
Imitrex is appropriate for chronic migraine. Again, like you said, without doing a full exam and stuff, I would say just from your description that you have some aspect of more than one type of headache occurring. So I would say that anything that presents with chronic migraine symptoms specifically, any headache you have that might be associated with nausea, vomiting, visual or hearing disturbances, I would say that should help. Any that it do not present that way, I would not expect much relief from it.
So you said
That would be classified as a visual disturbance. You would have to meet all the specific criteria for the migraine that we had on the slide to really truly diagnose you with chronic migraine. So this is very specific criteria for chronic, to be able to diagnose you with chronic migraine.
I mean, there is a sensitivity to light, but it's the vision is the wavy lines that maybe more than the actual pain, headache pain.
Sure. If you experience a lot of these other, or all of these other symptoms, then I would say, yes, you do have chronic migraine, but without kind of doing a full assessment and whatnot on you, it'd be tough to say.
Can can fluorescent lighting be a trigger?
Yes. Yep. I wouldn't say that there's something that would not be a trigger, because all patients have something different that they say triggers that. So, yeah, absolutely that can be.
I've got a question.
Yes.
So, I don't have, migraines all the time, but I can tell the difference between a migraine and a bad headache. But I know I have chronic headaches.
Sure.
So with chronic headaches, can I get treatment like a migraine, like to get trigger point injections and stuff like that for chronic headaches
Yes.
also?
Yep. So, really the only treatment that is specific to chronic migraines is Botox injections. That's the one thing where they want to see all of these criteria checked, are the Botox injections for migraines. But yes, trigger points, things like that we can do for chronic headaches.
Because I know in my younger years, I used to get migraines, and I could tell because I had the upset stomach and
Yep.
sometimes vomiting, and the light especially, I'd have to darken the rooms and that type of thing, so I know that was migraine. I don't get that as much anymore, but I have headaches all the time, probably 5 or 6 days a week.
Sure.
I have them all.
And do those start from back here?
Yeah, they're all in the back.
Yeah. Could either be, we said cervicogenic coming from your neck, myofascial coming from the muscles, or
Yeah.
some sort of nerve entrapment.
Occipital neuralgia
Yeah.
kind of sounded the most like what I might have, but
Sure.
the other one sounded like it also.
Yeah. What really, I guess, divides that out is a physical exam. So figuring out where, if neck movement is a huge trigger for it, it's likely coming from the neck,
Yeah.
arthritis in the neck. Then we can do imaging, figure out where the facet joints are kind of the most specific thing to that. Figure out if you have arthritis in those joints, and then we can do injections into, or the nerves around them, and ablation. So, yeah.
Is treatment for migraines different for, I'm assuming it probably is, but for somebody that gets a migraine, just say once every 5 months versus somebody that has them 3 times a month?
Yeah, so,
I mean, would you still use the same treatment?
nope, so I wouldn't classify either of those as migraines. So if you look at this diagnostic criteria, you have to have these headaches 15 days or more per month, every month, for 3 months at a minimum. So if you're only having one every 6 months, I would say you do not. It could be a migraine, it's not chronic migraine, in which case none of these interventional treatments would likely,
Be used?
correct.
Okay.
Yeah, yeah, so we deal more with chronic conditions lasting greater than 3 months. Yep.
Well, thank you, everyone. Can I have a round of applause for Jesse? Very interesting, and since you've been here the last couple of years, the growth of our pain clinic has I think 4 times busier, 4 more days, or 3 more days than we had originally. So it's certainly been helpful for a number of patients in our community, and actually regionally, we've seen a number of people traveling to our community to seek us services. So appreciate you willing to do this and serve the community of Sibley. So thank you. Have a great day.